Hi, my name is Catherine Gonzalez Castro. Let's go to talk about early or the later cardioversion in recent once atrial fibrillation. My tutor is John Moscoso. Definition. Atrial fibrillation AF is the most frequent cardiac arrhythmia in clinical practice. AF is a disease characterized by uncoordinated and disorganized atrial beats, production a rapid and irregular heartbeats.
Your heart. It pumps blood around your entire body, coordinated by an incredible electrical system. Normal heartbeats begin when your SA node fires an electrical impulse. This makes your atria contract, forcing blood into your ventricles. When the impulse reaches your AV node, it pauses before moving through your ventricles. This makes your ventricles contract, forcing blood out of your heart and around your body. If you have atrial fibrillation, the electrical impulses might start in other parts of your atria. These impulses can make your atria quiver or fibrillate. When the impulses reach your ventricles, they will also beat irregularly. Over time, atrial fibrillation can lead to clots forming in your atria, which increases your risk of stroke.
Application is nursing. The objective of the nurse in the treatment of atrial fibrillation in hospital emergencies will be directed to the correct administration of the drugs of choice, to the early detection and to the control of the after effects that may appear. The algorithm that must be followed at the hospital level includes the following points: electrocardiographic and constant monitoring, continuous monitoring of ECG.
It was a Monday morning and I had almost like two hearts. One was beating reasonably normally, the other one was racing. I went to the doctor's that morning. She checked my pulse, checked everything, and I was beating about 93 with the normal and 187 with the other one. At the hospital, I was given an ECG, checked everything, and was monitored for 24 hours and confirmed that I got AF. Then on the Wednesday, I went in for a cardioversion. They then kept me monitored for about 12 hours, and then the following day I was allowed out and everything seemed to be okay. I did think it was possibly something like a heart attack. I started getting tingling in my fingers and pain in my chest and down my arm, and I thought, this isn't right. So they took me into hospital and confirmed that I got AF again.
When Philip came into hospital, he was only taking aspirin. With the new NICE guidance, aspirin plays no part in stroke protection. So it's very much now the importance of starting them on anticoagulation. And my role when I saw him in clinic was to stress the importance of why he was commenced on this medication.
I feel I was kept informed of all the decisions and I was kept in the loop. They explained everything they were going to do, everything they did, the reasons for it, and the possible outcomes. Since I had the cardioversion, my life has returned almost to normal, but compared to what it was, it's a good 100% better than it was.
It's just so nice to see someone that was so debilitated with breathlessness and tiredness that when you cardiovert them on the day, that he was just full of beaming smiles and waiting for his holiday.
Pros and cons. Pros. Control of heart rate, of correction of the reading. Control of heart rate, of correction of the reading, through space to sinus rhythm. Anticoagulant treatment have consistently shown a reduction of embolic events, as well as reduction in mortality. Cons. Prolonged atrial fibrillation leads to cardiac remodeling and can lead to cardiomyopathy and congestive heart failure. Atrial clot formation.
Clear? Yeah. You wanna? Okay. Oh my God. Okay. You wanna move it? Yeah, please. Change it. Okay. So you don't have. We're gonna have to talk him again. Go ahead. You wanna give a little bit more? No. He's holding it. Lower it. Okay. Clear? Clear. Oh my God. Okay. Just take a deep breath. Good. What is he? AFib? Such a young guy, huh? Yeah. We're gonna have to do it again. They gave that hold of his demon pen.
I don't know.
Good. Okay. Good to go.
Clear?
Clear.
Oh, God.
Okay. Deep breath.
Okay, there we go.
Got it.
How much?
Okay.
How low?
100 joules.
100 joules?
Issue applied in Ecuador. Beginning at age 18, 1 in 10 older adults have it. In this case, it is also due to the aging of the arteries. Before that age, at least 1% of the world population suffer. Under 15, the possibility is 0.3. After that age, it gets X. It is estimated that in Latin America, there are 3.3 million people with arrhythmia, of which half do not know that they have it. Of the half that now is, 15% is not trained, and the other half that is being trained is bowler trainer. It is very difficult for those over 18 years to have. It becomes a chronic disease.
Fairly well worked out epidemiologically is there is an increased risk of heart failure, an increased risk of dementia, and interestingly enough, an increased risk of all-cause mortality. And that's adjusting for all of the risk factors for those conditions that are associated both with the outcome and with atrial fibrillation. Another reason why it's an important problem is as we've gotten better at treating cardiovascular disease, people are living longer, and they're living longer with chronic cardiac conditions, and so they have more time to actually develop secondary conditions or other conditions such as atrial fibrillation. So it's been observed in multiple data sets looking at the same question multiple ways that the prevalence of atrial fibrillation is increasing on the order of 2.5 to 3 million today. By the year 2050, it's estimated that there will be on the order of 6 to 12 million Americans with atrial fibrillation. So it's a very large problem. Part of that's the aging of the population, but over and above the aging of the population, it appears that the prevalence, or how common the condition is, has been increasing. So the goal of the American Heart Association is ambitious, and part of it is to decrease death and disability from stroke and cardiovascular disease by 20%. But the American Heart Association has shifted its philosophy, in part responsive to patients, to healthcare advocates, and the general public, to realize that it's not enough to be free from cardiovascular disease and its ravages. We're really emphasizing healthy living and living longer in optimal or good states of health.
Conclusion. Patient with recent-Onset atrial fibrillation commonly undergo immediate restoration of sinus rhythm by pharmacology or electrical cardioversion. However, whether immediate restoration of sinus rhythm is necessary is not known now, since atrial fibrillation often terminates spontaneously, like
If you have an abnormal heart rhythm, your doctor may perform electrical cardioversion, where he or she uses an electrical shock to restore your normal heartbeat. The heart normally beats in a regular rhythm at 60 to 100 beats per minute. This steady and coordinated rhythm allows the heart to effectively pump blood. Electrical signals that travel through the heart control the heart's rhythm. These electrical signals start in a cluster of cells called the sinoatrial node, or pacemaker. The sinoatrial node, or SA node, is located in the wall of the right upper chamber of the heart, called the right atrium. When the electrical signals reach the heart muscle, they cause it to contract and pump blood. An abnormal heart rhythm is called an arrhythmia. During atrial fibrillation, the atria quiver because of chaotic electrical signals in the heart, resulting in an abnormally fast or irregular heartbeat. Because of the abnormal heartbeat, blood may pool in the atria, which can result in the formation of a blood clot. If the blood clot passes into the general circulation, it may cause a stroke. Before the procedure, you will be connected to an intravenous line. You will be sedated so you will sleep through the procedure. EKG electrodes will be placed on your chest to monitor your heart's electrical activity. Once you are sedated, special cardioversion pads or paddles will be placed on the skin of your chest or your chest and back. These pads or paddles will deliver electrical shock through your chest to your heart. The shock may be repeated several times until the heart resumes its normal rhythm. After your electrical cardioversion, you will be monitored closely in a recovery room or in the coronary care unit of the hospital. Once the sedation wears off and you are in stable condition, you will be sent home.